So, talking about anticoagulants. Anticoagulants oral bioavailability is 80% of rivaroxaban, and the half-life is 7 to 11 hours, and there is dual mode of elimination. One is that 1/3 gets cleared via kidneys. It's cleared as unchanged drug. Whereas 1/3 is first metabolized in liver and then excreted in feces, and 1/3 is metabolized in liver and this then excreted via kidney, and it's a substrate of PGP. If other drugs which inhibit PGP, for example PGP and CY3Y4 inhibitors, are given along with it, rivaroxaban drug level will increase. So drug level increases if PGP inhibitors or CYP3A4 inhibitors are given along with it. What the rivaroxaban dose is 20 mg OD if creatinine clearance is more than 50 ml per minute. But if creatinine clearance is 15 to 49 or this two or more of the following are present, for instance age greater or equal to 75 and weight less than 60 kg, so less weight but age is higher or has blood score greater or equal to 3, then we should put the dose of 15 mg per 24 hours. So dose regimen, for instance you encounter a patient with acute VTE. How will you treat this? You have to give 20 mg daily dose, but there is a catch. You have to give 15 mg BD initially for 21 days, followed by 20 mg OD. And this is for treatment of acute VTE, acute venous thromboembolism. Now, if a patient has undergone knee or hip replacement, then what you will give for knee replacement and for hip replacement, there is treatment for 14 days, and for hip there is 30-day replacement, and the dose is same, that is 10 mg OD. And for AFib the dose is 20 mg OD if GFR is greater or equal to 50. Thus in nutshell, for AFib dose we have 20 mg. So for AFib we have 20 mg per day dose, and if only if creatinine clearance is greater than 50. But if creatinine clearance is 15 to 49, or if age is greater or any two of the following, that is age greater or equal to 75, weight less than 60 kg, or if patient has blood score of greater or equal to 3, then patient is to be put on 15 mg OD. So AFib treatment is 20 mg OD, VTE is 15 mg OD for 21 days, followed by 20 mg OD, and DVT prophylaxis is always 10 mg OD. Sorry, this is 15 mg BD for 21 days, followed by 20 mg OD. So for the initial days the dose is high, 30 mg for initial 20 days, then followed by low dose 20 mg OD. And so AFib 20 mg per day if creatinine clearance more than 50, VT is 15 mg BD for 21 days, followed by 20 mg OD. For prophylaxis 10 mg OD, and also chronic coronary syndrome 2.5 mg BD is the dose. It is as per COMPASS trial. But this rivaroxaban has increased risk of GI bleed, so in patients with melena you avoid this. Or if patient have, for instance, pancytopenia with thrombosis, for example patient with paroxysmal nocturnal hemoglobinuria, there will be low platelet count and you are giving treatment for VT, So this is a potential candidate. There can be bleeding if already patient is having melena or something. So rivaroxaban has increased risk of GI bleed, especially in those who have underlying malignancy. Thus helps up in picking up those patients. Advantages of rivaroxaban is ICH and fatal bleeding. ICH and fatal bleeding occurs less frequently in those receiving rivaroxaban, and there is no differences in the risk of major bleeding. Also in acute coronary syndrome, as per Atlas trial, acute coronary syndrome as per Atlas trial, there is increased bleed, that is major bleed plus ICH, but not the fatal bleed, and so there is decreased cardiovascular event. Net result is plus minus, hence there is no recommended regime of adding rivaroxaban in ACS. You see, what if a patient has creatinine clearance of less than 15, creatinine clearance of 15 to 45, and creatinine clearance of more than 45 or more than 50, 49 or more than 50. So see, we know the dose here is 15 BD for 21 days, then 20 OD. Here rivaroxaban is still approved for VT treatment in creatinine clearance of greater than or equal to 15, that is this range, with no dose modification. So there is no dose modification here. So start with 15 BD for 20 and then 20 mg OD, but close monitoring has to be done. But at this stage, what happens? Rivaroxaban is not recommended if creatinine clearance is less than 50. So rivaroxaban is contraindicated here. Also in elderly, frail, low body weight patients, or if patient is on interacting medications, consider directly oral anticoagulant dose monitoring for alternatives. So what is the best drug? What is the alternative in CKD patients? So you see, apixaban is better studied in CKD patients, including dialysis patients, and enoxaparin can be used. Adjusted dose in CKD. Warfarin is an option in creatinine clearance. So warfarin is also a good choice here if creatinine clearance is less than 15 ml per minute. Because you know already that rivaroxaban 66% is excreted via kidneys. That's why dose modification is to be done. So let us, there is a question: a patient with acute DVT with creatinine clearance of 28 ml per minute is planned for rivaroxaban. What is your approach? So creatinine clearance is above 15, so 15 BD for 20, then 20, but monitor for bleeding and renal function regularly. Avoid if creatinine clearance is less than 15. Now coming to apixaban. Apixaban is predominantly metabolized in liver and predominant metabolism in liver. So it has also it is compared to other DOACs, it has least bleeding complications. So it has least bleeding complications. Third is it has greater efficacy. And efficacy of warfarin with bleeding risk of aspirin has been compared. Now you know that this apixaban, if creatinine clearance is more than 50, and if creatinine clearance is 30 to 50 and less than 80 years of age and greater or equal to 60 kg, then 5 mg BD is the dose. 5 mg BD for AFib is the dose. And so let us see, if creatinine clearance is greater or equal to 50, or creatinine clearance is 30 to 50 and age is less than 80, or weight is greater or equal to 60 kg. So this is first and this is second. So here he has more weight. Here you will give for AFib treatment 5 mg BD. So total 10 mg is the dose. Now if patient has creatinine clearance of 15 to 29, one option, or two or more of the following. One is creatinine of 1.5 milligram per deciliter, or age greater than 80 years, or weight less than 60 kg. Then 2.5 mg BD is the dose. So this dose is of DVT prophylaxis. So we know that here we for rivaroxaban for 2 weeks is the treatment prophylactic dose for knee, and for hip it's almost 5 weeks, so 14 and 30. Likewise, when we give DVT prophylaxis in knee and hip replacement surgery, we give prophylaxis for 2 weeks, that is 14 days, and 5 weeks here, around 45 to 50 days we give this treatment, and the dose in both the cases will be 2.5 mg BD. This is the normal prophylactic dose here. But what about DVT or PTE treatment? What is the dose? Dose is 10 mg BD for 7 days, followed by 5 mg BD. This is the dose. So only trial of DOAC in AFib which showed lesser mortality was with apixaban, and with apixaban that decreased overall strokes and systemic emboli. The overall strokes and systemic emboli decreased, although there was no difference in rate of ischemic strokes. Apixaban decreased ICH risk, but GI bleed is similar with that of warfarin, although all-cause mortality was found to be significantly lower in apixaban group. So, so here is a question. An 82-year woman with 70 kg weight with non-valvular AF with serum creatinine of 1.6 milligrams per deciliter. What is the dose of apixaban that you will start with? So here, as you can see, we have to treat AF to prevent stroke. So this is the nutshell, what is the goal here. And so dose can be either 5 mg BD or dose can be either 2.5 mg BD. But for AF we usually use this dose 5 mg BD. But what is the catch here? Female patient, age greater than 80, weight less than or equal to 60, creatinine of greater or equal to 1.5. So if 2 out of 3 is fulfilled, then you have to treat AFib with 2.5 mg BD. So what is being fulfilled here? You see, age is greater than, so one criteria is fulfilled. Weight is less than 60, so this is not fulfilled, but creatinine part is fulfilled, so you have to give 2.5 mg BD. What if the same case was changed to valvular AF? Valvular AF. So in clinical terms, valvular AF is AF in the presence of either moderate or severe mitral stenosis, usually rheumatic origin, or mechanical heart valve. And note that everything else, that is mitral regurgitation, aortic stenosis, for example biprosthetic valves, repaired valves, hypertensive heart disease, is classified as non-valvular AF. So why does it matter? Because direct oral anticoagulants like apixaban, rivaroxaban, dabigatran, and endoxaban, they are not recommended. They are not recommended in valvular AFib. these patients, so patients with these valvular AFib patients, they have a very high risk of thromboembolism, and that was not adequately studied in DOAC trials, direct oral anticoagulant trials. That is why we don't recommend them. So the preferred anticoagulant is warfarin with an INR target of 2 to 3, sometimes 2.5 to 3.5 for mechanical heart valves. So let's frame a question. A 70-year-old woman with atrial fibrillation and a history of rheumatic heart disease with moderate mitral stenosis is planned for anticoagulant. Which of the following is appropriate? Warfarin with INR goal of 2 to 3 or dabigatran? Obviously warfarin with INR goal of 2 to 3. So if a person has AFib plus moderate mitral stenosis, moderate to severe mitral stenosis, especially of rheumatic origin, then it is classified as valvular AF. Similarly, AFib with this mechanical prosthetic valve, this is also termed as valvular AF. Now if a patient has AFib with, for example, mild MS, similarly MR, other things, AR, AS, whatever, this all is classified as non-valvular AF. Also note that if patient has AF with moderate to severe mitral stenosis, even if it is not due to rheumatic heart disease, this is still classified as valvular heart disease, valvular AF. This is classified as valvular AF. And note that risk of thromboembolism in AF increases significantly once mitral flow is obstructed, regardless of the underlying cause. So whether the mitral stenosis is rheumatic or non-rheumatic, moderate to severe stenosis impairs LA emptying, promotes stasis, thrombus formation. So the pathophysiological basis, that is a blood stasis in LA due to obstruction, is what drives the decision, not only the etiology. But practically speaking, greater than 90% of cases worldwide, greater than 90% of cases worldwide, so we see moderate to severe mitral stenosis is due to rheumatic heart disease. So greater than 90% is due to rheumatic heart disease, especially in India and developing countries. Whereas other causes like mitral annular calcification, radiation induced MS or congenital MS are rare and often mild. So guideline wise, AHA ACC 2023, EHRA 2021, the term valvular AF is not depreciated in some guidelines, replaced by AF with moderate to severe MS or mechanical heart valves. These are the only two situations where DOACs are contraindicated. And no matter whether MS is rheumatic or not, just the anatomical functional severity matters. So now if a patient has, for example, a 76-year-old woman with atrial fibrillation with moderate MS due to mitral annular calcification, that is actually a non-rheumatic, what anticoagulation will you put? You will put warfarin with an INR goal of 2 to 3. DOACs are contraindicated in moderate to severe MS regardless of cause. You see, warfarin is vitamin K antagonist and the metabolism is hepatic and it is metabolized by CYP2C9. It's not cleared by kidneys. All the monitoring is with INR and reversal is with vitamin K, FFP and PCC. Warfarin initial dosing start low and go slow. In healthy adults, for example, average we use 5 to 10 mg per day, and in elderly greater than 70 years or patients are frail or patients have liver disease or drug interactions or low BMI, we give with 2.5 to 5 mg per day. And CKD or AKI, any stage, we start with same dose, 2.5 to 5 mg per day. And our goal is typically 2 to 3, except in some cases mechanical mitral valve, we put INR goal of 2.5 to 3.5. So warfarin dose is not renally cleared, so no dose adjustment is needed for creatinine clearance. So whatever creatinine clearance is, just give 2.5 to 5 mg OD. So no dose modification is required with any creatinine clearance, and it's safe to use in CKD SRD, but start as low dose and monitor INR frequently. So if a patient is AF with moderate to severe MS, INR goal is 2 to 3. AF with mechanical valve, 2.5 to 3.5. In case of mitral, 2.5 to 3.5, but in aortic, 2 to 3 is the goal. And for VT, DVT, PT, it needs bridging, although INR goal is same 2 to 3. Also in APLA goal is 2 to 3, and also in biprosthetic valve after 3 months goal is 2 to 3. So normal creatinine clearance usually 5 to 10 mg per day, but if creatinine clearance is below that, start with lower doses, 2.5 to 5 mg OD. In CKD SRD dialysis patients, safe to use, no renal clearance. Also in AKI. So bridging, do you need bridging? So bridging is use of heparin, be it unfractionated heparin or low molecular weight heparin, until INR becomes therapeutic. So bridging is required. Yes, in acute, where is bridging required? So in patients with this acute VTE, or be it TVT or PT, bridging is required as with unfractionated or low molecular weight heparin. So you have to overlap with heparin for 5 days, and INR for greater or equal to 2 for 24 to 48 hours. So you give overlap with heparin for 5 days, and INR for greater or equal to 2 for 24 to 48 hours. Also in mechanical heart valves you will give bridging. Also with AF with rheumatic MS you will give bridging. Perioperative interruption in high risk, bridging needed. Starting warfarin in APS, bridging needed. Bridging is not needed in chronic stable AFib, that is non-valvular. So if a patient has active GI bleed, you stop warfarin and you reverse with vitamin K plus PCC or FFP. If a patient has history of GI bleed, you can restart. Carefully after 7 to 14 days as per NEJM 2012, depending upon indication. And use proton pump inhibitor co-therapy to reduce rebleeding risk. AKI, it is safe. And so if a patient, for example, a question is there, if a patient 70-year-old man with new proximal DVT with EGFR of 22 ml is planned for warfarin, what is the next best step? We know that patient is having low GFR 22 and the patient has developed new proximal DVT. We can start with Epixa, but we can also start with this warfarin. So if we give warfarin, we have to give dose of 2.5 mg per day to 5 mg per day, plus simultaneously we have to use low molecular weight heparin or unfractionated heparin as bridging, and we have to monitor INR. What happens if a patient has developed DVT and you start him alone on warfarin? So what happens, warfarin creates a temporary hypercoagulable state in the first 24 to 48 hours. because warfarin also reduces natural anticoagulant protein C and protein S, that too very early. So if you start warfarin alone in acute VTE, patient may clot more or develop warfarin into skin necrosis. That is why bridging is necessary. So you start warfarin with heparin, be it unfractionated or low molecular weight heparin, together on day 1, and you continue both for greater or equal to 5 days, even if INR has become therapeutic earlier. So for instance, if we have given warfarin plus you have given low molecular weight heparin and it is day 2 but INR has become 2, so what will you do? You will continue it both for greater or equal to 5 days, even if INR has become therapeutic earlier. And then you will check INR daily after day 3. You will check it daily, and you will stop heparin only when warfarin has been taken for greater or equal to 5 days and INR is greater or equal to 2 for at least 24 hours, some say 2 consecutive readings. This ensures that full anticoagulation effect of warfarin has kicked in safely. So rule is heparin for greater or equal to 5 days to allow time for full warfarin effect to deplete prothrombin or to increase prothrombin clearance, and INR of greater or equal to 2 for 24 to 48 hours. So bridge for 5 days plus keep INR greater or equal to 2 days for 24 to 48 hours. So for instance, if a 62-year-old female with acute DVT, she is started on warfarin of 5 mg plus enoxaparin of 1 mg per kg BD. On day 3, INR is 2.1. So what will you do? It is day 3, so you will not stop enoxaparin. You don't have to stop heparin yet. You have to complete it for greater or equal to 5 days, and on day 6 you will check INR, and if INR has remained 2.3, you can stop low molecular weight heparin. A patient with acute PT is started on warfarin and low molecular weight heparin. On day 4, INR is 2. What is the best course? Continue LMWH and warfarin only. Stop LMWH after greater or equal to 5 days of overlap and INR of greater or equal to 2 for at least 24 hours.